Good afternoon, everyone. It's great to be with you today. Welcome to today's nonpartisan virtual briefing. I want to thank you for taking the time out of your day to join us. I'm Alyson Northrup, a senior policy officer at the Robert Wood Johnson Foundation. RWJF is a leading national philanthropy dedicated to taking bold leaps to transform health in our lifetime. For more than 50 years, RWJF has been a trusted resource for data and analysis that inform policies to improve health and well-being in the United States. And today, we will discuss the state of healthcare coverage in the United States. Access to health coverage plays a significant role in determining whether people get needed healthcare. However, many people struggle to find coverage that is affordable for them and their families, and millions of people across the US currently live without the peace of mind that access to affordable, comprehensive health coverage brings. Of course, healthcare coverage is very much a topic du jour on Capitol Hill. However, the purpose of today's discussion is not to endorse or debate specific proposals or pieces of legislation, but rather to provide a look at the existing body of research on healthcare coverage, current trends, and practical considerations for policymakers heading into 2026. I'm looking forward to the conversation. I hope you are too. Before we dive in, a few programming notes. We'll have plenty of time for Q&A, so feel free to share your questions in the Q&A box throughout the discussion. A recording of today's discussion will be shared with you in a follow-up email, along with resources referenced during today's discussion. And near the end of our time, we'll share a link to a brief survey in the chat. We appreciate you completing it as we work to use your feedback to inform future briefings. Lastly, before we begin, I want to make sure attendees of today's briefing are aware of an RWJF-supported resource called the Congressional District Health Dashboard. This tool is a partnership between RWJF and the NYU Grossman School of Medicine. The dashboard tracks data on health and its drivers, including rates of insurance coverage by congressional district, as well as state level information as well, and places this information directly at the fingers of policymakers and staff. You can visit congressionaldistricthealthdashboard.org to explore the tool and find data specific to your congressional district and state. With that, I am happy to introduce our speakers for today. Katherine Hempstead is a senior policy advisor at RWJF. She is a national expert on healthcare and health policy issues, particularly when it comes to the Affordable Care Act and its marketplaces. Kathy tracks health insurance trends, costs, and changes in access to care, informing discussions at the federal and state levels through her rigorous analysis of data that she's able to translate into expert insights that are understandable for everyday audiences. She's also the author of a new book, Uncovered: The Story of Insurance in America, which covers the history of the insurance industry and its regulation in the US. Hemi Tewarson is the executive director of the National Academy for State Health Policy, also known as NASHP. NASHP is a nonprofit and nonpartisan organization committed to improving the health and well-being of all people across every state. At NASHP, Hemi leads an organization that is at the forefront of engaging state leaders and bringing together partners to develop and advance state health policy innovations. I'm grateful to have them both here today, and I'm going to turn things over to Kathy. Could you start by giving us an overview of health coverage at the national level?
Thanks, Alyson. Good afternoon, everyone, or good afternoon, everyone. It's great to be here on one of our final big events before we go on our holiday break. And I wish I could be there in person, but it's nice to virtually be with all of you. And I thought I would just speak very briefly about a couple of big picture issues, and then Hemi will as well, and we'll have lots of time for Q&A. And I thought I would talk a bit about kind of a top line view of healthcare cost growth in this country, why coverage is such a hard issue in our system, and thinking about some of the current issues from both a short-term and a longer-term perspective, because I think we have challenges in both respects. And you can go to the next slide, please. Usually, American exceptionalism, it can mean a lot of different things, but a lot of times it's something that we feel pretty good about in the US when we talk about American exceptionalism. But I think what we're talking about today, is a way in which we are different in the US, but in a way that I think a lot of us think is pretty unfortunate. And I'm sure you've heard this before, but I just wanted to start out by noting that compared to other nations that we might compare ourselves to, in terms of income, age composition, educational level, et cetera, we spend an awful lot more on healthcare. So here are some recent stats on spending per capita. The bar graph shows 2023, and then we have a little bit of updated numbers in the bullets, but you can see that we're currently spending about 15.6 thousand per capita in 2025 on, sort of all in on healthcare. And that's nearly twice as much as the average of what we consider sort of our peer nations, who provide, healthcare to a pretty similar population, but spend a lot less doing it. And so, not surprisingly, as a share of GDP in the US, we're getting close to 20%. We're 18.5% right now. 2023 data there for peer nations closer to 11%. Still significant, but quite a bit less. And I think one of the things that is worth thinking about here is, what's going on? Why do we have this big difference? Healthcare spending is basically the product of prices and utilization. It's what healthcare services are we using? How much are we spending for them? And in the real important explainer of the difference between the US and other countries is not so much that we use more healthcare, but it's that we pay more for it. And there have been many studies on this. The Commonwealth Fund does a ton of really great stuff on this, so you can dive into the details. But we spend more on administrative costs for insurance, for providers. We pay more for drugs, which, we talk about a lot. And we also spend a lot more for hospital care, pay higher wages to providers. So right down the line, we really spend more for everything that we get in healthcare. And that is a bigger explainer of why we have higher healthcare costs versus the idea that we're using more healthcare or making more visits to doctors and hospitals. So prices are really key in explaining what's different about the US. You can go to the next slide. Thanks. And then just thinking about how do we break down that healthcare dollar, because if we want to think about how could we reduce healthcare spending growth, what are some of the big things to look at? And, not surprisingly, the biggest single category is spending in hospitals, and then spending on physicians and clinics, another 20%. Prescription drugs is 9%. So it's about sort of 60% on the healthcare services and prescription medication that you would expect. And then there's a big other category that you might want to dig more into later. But one of the big points in there is also the sort of administrative and net cost of insurance, which includes both the insurer's administrative costs and also their margins. So we, but when we break down the dollar and we say, what do we spend a lot on? It's, it's not surprisingly, it's healthcare that takes place in hospitals and doctors' offices, and also prescription drugs. You can go to the next slide. Thanks. And so not only are the levels high, but the trend is pretty bad. And I'm sure, again, this is something that is not a secret and it's not really news, but I think it's worth talking about right now, because we're actually having a, particularly unfortunate year or two in terms of trend, where across the board, we're hearing that prices have gone up more than usual, and that utilization has also been above trend in the last year or two. So I think you've probably heard a lot of stories about how employer insurance renewals are going to be very high this year, with people seeing 10-15% increases. And, we have heard in sort of all parts of the health insurance business that there is a big increase in costs. And the graph on the right is showing you the share of our GDP that goes to healthcare spending, and you can see a projection to hit 20% pretty soon. I love this quote from Warren Buffett that describes healthcare spending as the tapeworm of American competitiveness. And what that really alludes to is the fact that healthcare spending increases a lot more quickly than wages. And it's something that suppresses wages because so many people get their health insurance from work, and the employer share of health insurance premiums is sort of eating up part of their wages. And the graph on the left is kind of interesting because I think with so much interest lately and talking about affordability and inflation and how much things cost, it's worthwhile to look at increase in the cost of these different components of things that people can spend money on, as well as wages, and see that the Milliman Medical Index, which is kind of the average cost of an employer plan for four, which by the way is estimated to be about $35,000 in 2025. The cost of that package of insurance has increased almost 200%, way more than wages and way more than groceries, gas, other kinds of things. So, the point there is that the growth in healthcare costs have suppressed wages and kept wages from rising as much as they would otherwise, because so much of that, of what would maybe be reflected in wage increases is subsumed by paying for healthcare, and that healthcare has become more expensive relative to other goods. So people who can afford gas, who can afford rent, who can afford other things, really struggle to afford healthcare. Okay, you can go to the next slide. Thanks. So this brings us to coverage. I mean, because healthcare is so expensive, very few people can sort of self-insure against what they might have to pay and that face a kind of unlimited financial downside. So coverage is really essential, but at the same time, coverage is also really expensive. And another way in which the US is exceptional or different than our peer nations is that we haven't done the same job of covering everybody. And we've kind of struggled to figure out ways so that everybody has an affordable offer of coverage, which I think is, something that probably most people would think is a good idea. And we have made some strides in recent years. And I love this graph from the Commonwealth Foundation, which shows 2 dots for each state. And it shows the decline across the board in every state in the uninsurance rate since I think it's 2003. And you can see that, the differences between states are getting smaller. There still is a difference, but uninsurance declined in every state. And we've seen a reduction in race differences in uninsurance and seen a lot of gains for people. But I think that as we're all aware, we're kind of at risk of reversing some of those recent gains with some policies that are coming down the pike that are going to, according to CBO, potentially result in as many as 15 million people, which is an incredibly large number, losing their coverage over the next 10 years. And just for context, we have about 27 million uninsured people now. So that would be an extremely large increase in the size of the uninsured population. And, it's no mystery what happens when people lose their coverage. And we actually were able to study this in reverse when we saw the impact of coverage gains. But there's obviously health and financial consequences for families. People put off symptoms and don't get treatment until maybe it's too late, or they have to show up in a more expensive setting where they feel more confident they're going to get care. So there's a big impact on the health system, both in terms of missed revenue from regular visits, but also bad debt or charity care that comes up when people show up for expensive treatments and services and can't pay for them. It also affects the employer market because providers then are seeking to try to make up for some of the money that they're losing when there's an increase in uninsurance. And so it can be seen as something that can contribute to a broader context of rising costs. Another thing that will happen when people feel like their insurance they still have insurance, but it's increasingly unaffordable for them, is they may buy down to a lower actuarial level plan or get a high deductible plan. And then people may feel as though they can't get care because they, don't have the money, or they have to go get some kind of a screen or test or something, and they get a bill for, many hundreds of dollars and they can't pay it. So I think medical debt, which is already a problem, is something that we would also expect to see as being exacerbated by an increase in uninsurance and sort of underinsurance when people don't have enough protection from financial exposure. You can go to the next slide. Thanks. So the individual market is a relatively new and growing piece of our healthcare ecosystem. It was created by the Affordable Care Act, and it filled an important gap, for people who were working age, but didn't get an offer of coverage from an employer. So they didn't qualify for Medicaid, they didn't qualify for Medicare, and they really had no other source of coverage. And given everything we've just been talking about how much healthcare costs and how much coverage costs, very few people could go out and pay for something like the Milliman Medical Index PPO for a family of four on their own. So we have this subsidized individual market where the idea is that people are supposed to have an affordable offer and pay some share of the premium cost, and also have some cost sharing that goes along with that. And the people that use this marketplace are, it was kind of intended for people who are self-employed. So we see a lot of self-employed people there. We increasingly see small business, both owners and employees in there, and the small group insurance market has become increasingly expensive and kind of selected against, and we're seeing an increased migration of small business to the individual market. It's especially important in rural areas where there's less employer insurance, and there are a lot of self-employed people like farmers and other people in the agricultural economy that really need coverage. And older adults in general. You can also think about situations like someone who retires from work a few years early to be a caregiver for an older spouse. The older spouse may be eligible for Medicare, but the other spouse is not. So the individual market can be very important for older retirees, especially when they have family caregiving obligations and they can't be in the workforce anymore, but they still do need coverage. And the coverage itself is very much like employer coverage. It covers the same things. It has provider networks. It's very, very similar. Tends to have slightly narrower networks than many employer-sponsored coverage, and also the prescription drug cost sharing can be a little bit higher. And the enhanced premium tax credits, which is certainly a subject of a lot of discussion lately, what were put into place a few years ago, and they greatly increased the affordability of the plans, really for everybody. And for people whose income was above 400% of the poverty level, it took them from having no tax credits to having a tax credit. So it made coverage a lot more affordable for that population. And it's just important to remember that people that use this market, by and large, really don't have an alternative. So if they lose access to affordable coverage in this market, they very good chance they'll end up uninsured unless they change jobs or do something pretty drastic. Okay, you can go to the next slide. Thank you. And just to talk a little bit more about the impact of ending these enhanced premium tax credits, which are, definitely set to expire at the end of 2025. There's been a lot of coverage of sort of the empirical effect of this. What is it going to do to people, where we see average premium increase of about 100%, which, that's an average. For some people, it's going to be a lot more. For some people, it's less. It's especially a big deal for older people who have to pay higher premiums because the premiums are age rated. People in rural areas where coverage can be more expensive because healthcare just costs more in rural states. And for people that are leaving the subsidy cliff and are going to go to an environment where they don't have any tax credit, but they're being asked to pay for something that's very expensive. And in some of these instances, people will be asked to spend approximately 20% of their income on premiums, which is, a really hard thing for people to do. The impact of the end of these tax credits, you can sort of think about how it affects people and people in different states or people with different characteristics. There's a projection of a pretty significant contraction in the market, and a lot of people won't take their coverage. And others will buy down, are projected to buy down from, a silver plan to a bronze plan, or so buy down to a plan where they can afford the premium, but they're going to be exposed to more cost sharing. And there's also going to be an effect on the market, because we don't expect the exodus to be random. People who are more in need of using healthcare and really must have their coverage are going to be the ones that stay in the market, which will kind of drive up the the average cost of that market and, create some risks for insurers and, make the market basically smaller, but also more expensive, which is a negative. You can go to the next slide. Thank you. And, just to kind of mention, I'm sure this is something on your mind. There's been a lot of conversation about how to, whether to and how to address the issue created by the expiration of the enhanced PTCs. And, they include just extending them, and making no changes, extending them with, some modifications of the exact definitions of how they work and what the thresholds are at sort of the high and low ends of income. There's been a proposal to substitute a health savings account for the enhanced premium tax credit and combine a deposit of some amount of money in an account for people who also agree to purchase a lower actuarial value plan, like a bronze or a catastrophic plan. And then there have been some proposals to make other modifications to the ACA, such as appropriating cost sharing reductions and other changes that don't directly address the enhanced PTCs. And these are all things that are, quite the focus of activity lately as the end of the year draws near. You can go to the next slide. Thank you. And I guess I'll just close by saying that, whether there'll be a resolution to this issue or not, it's, there remain some very significant issues about the healthcare system and essentially cost growth that really are going to continue to, to demand our attention. At an individual level, the affordability of healthcare is a problem, and at a societal level, the growth in healthcare spending as a share of our GDP is also a problem. And I think it's not wrong to look at this issue with the enhanced premium tax credits as kind of a manifestation of this more upstream system issue. So I think it's something that many people are suggesting that we should take a harder look at. And there are, without going into tons of details, there are a number of opportunities to reduce healthcare cost growth. I mean, we're not going to make healthcare be cheap, and it's not cheap in any of our peer nations either. But reduce the trend in cost growth and make it more possible for everyone to have affordable access to healthcare without it, reducing their prospect of increasing their income or sort of strangle other elements of consumer behavior. And some of those ways include basically finding ways to pay less for things, which you couldn't, there are different kinds of proposals about how at the federal and state level we pay for different kinds of healthcare in different settings. There are proposals about reducing administrative costs. There are proposals about paying less for prescription drugs. And other strategies include ways to re-inject some more competition and transparency into the market, as well as other suggestions. So I think we should not lose sight of this longer term challenge, which is a very significant challenge when we think about how to resolve this short-term problem. And I think my last slide you can go to now. There was a really great opinion piece in the Times last week by Zach Cooper, who's an economist who studies healthcare cost growth, and made kind of this, this same point that, sure, there's this issue about the enhanced premium tax credits, but there's a sort of a bigger problem that, that this reflects, but that we still have to address. And I think they're pulling out a great quote from there and sort of talking so that you can read it. But it talks about how sort of growing healthcare costs have affected inequality and sort of economic hardship in the U.S. since 1975, as much as a lot of other things that we often, cite as being really negative, like outsourcing and automation, and that this rise in healthcare costs and the way it's sort of born has fueled inequality and left people drowning in unaffordable medical bills. So I think that that's a good point to end on. And, I hope the takeaway is that, yes, we have a short-term problem here, but we have a long-term problem as well that, there are ways that we could address it, and it would behoove us to think about them more. So thank you very much, and I'll turn it over to Hemi.
Thanks so much, Kathy. I'll jump in briefly just to give you some appreciation. I always feel smarter after I listen to you, and really helpful to have kind of that big picture overview of healthcare coverage trends at the national level. And now I am going to turn to Hemi, and have us go a bit deeper on the state perspective. So, Hemi, I'll turn it over to you to share a bit about the state perspective on health coverage and affordability. Take it away.
Thank you, Alyson, and great to be here. And what a great discussion that Kathy kicked off. So, I am Hemi Tewarson. One of the things I just wanted to share at the outset, we here at NASHB work with state leaders, and we work with a lot of different types of state leaders. We work with HHS secretaries, governor's offices, Medicaid directors and staff, insurance commissioners and their staff. And we also work with the state-based marketplaces and many others. So when I talk about, sort of state strategies around access and affordability, it really is trying to bring in all of those different perspectives into the conversation. Great, we can go to the next slide. Okay, so Kathy covered much of this, so this will be sort of the quick hits. When we work with our state leaders, they are much like you all are doing at the federal level, looking for strategies for this sort of long-term challenge of how do we slow the increase in healthcare costs, and how do we ensure that people have access to coverage in different ways. So this is just a snapshot of kind of where we are. The last available data is from 2023, from this analysis. And you can see here, nearly half of our population gets their coverage from employer-sponsored insurance. And that includes, for states, state employee health plans, and lots of other employers, large and small, that, work across our healthcare ecosystem. And then about a third of our population is enrolled in public programs across Medicare, Medicaid, and CHIP. One thing about Medicaid, which is interesting, and I'll touch on Medicaid at the end of my presentation, Medicaid and CHIP enrollment is at 77 million in 2025, so updated from 2023 here, and that's an 18% decrease from 2023. So the numbers on Medicaid have gone down as a result of the unwind, as you might remember, when folks were staying on the rolls after COVID and then were, redetermined, and some of them no longer were eligible for Medicaid. On the marketplace side, Kathy did a really fantastic job of an overview of the marketplace. I'll just share, just in terms of enrollment numbers, here in 2023, the individual non-group market was at about 6%. But given the growth over the past 2 years, since now in 2025, we are at a record high of marketplace enrollment with just over 24 million people. And that's about a 10% increase in this pie. And that really is, I think, as Kathy mentioned, a result of the availability of the enhanced premium tax credits that made that coverage more affordable for individuals. Okay, we can go to the next. Oh, one other thing I'll just say on the uninsured front, this is now at 8%. Just to note, in 2013, it was about double in terms of uninsured rates. So we have made significant progress in changing coverage rates for people over a span of 10 years. Okay, next slide, please. Okay, so Kathy covered a lot of this. The few things I just wanted to point out on this slide was the health insurance costs have increased exponentially since 2001. So this has been a sort of long-term growth pathway. This is not a result because of the last couple of years or following certain trends that are recent. This is a long-term trend. And when there are long-term trends and long-standing challenges, it will take a complex set of solutions to really figure out how to address all of this. But this graph just shows on the left from Kaiser Family Foundation, really just average annual premiums for single and family coverage. You can see the growth. I will say this is the employer-sponsored side, but I will say from the individual market side, the marketplace premiums, the growth looks very similar. So this is a larger market problem, not just with respect to marketplaces. As you remember from the last slide, about half of our population is in the employer-sponsored insurance category, and then the marketplace is, just under 10%. So this is sort of across a larger swath of increase in premiums, and how do we think about this as a sort of totality? On the right side, this is just a little bit about the coverage itself. So there has been an increase in, what people have to pay who have coverage, and that's in sort of two categories, deductibles and co-payments. This chart on the right here is just a snapshot of deductibles, and you'll see how many people are enrolled in a plan with a high general annual deductible in 2025. It is significant, and that is a challenge for folks because a deductible is what you have to pay before your coverage kicks in. So there is a lot of out-of-pocket costs that people have to incur before they can actually get insurance to cover the costs of their services. Okay, next slide, please. Okay, so one of the things that folks ask us when we work with state leaders, how much is inflation, contributing to this? And it's certainly a factor in the rising cost of healthcare and as a result, rising premiums for individuals. But medical care is really outpacing our consumer price index for all urban consumers. And you'll see the difference here in this chart. So although inflation is a piece of this, it is certainly not really the majority of the cause of what's happening. Okay, next slide, please. All right, so this chart was Kathy shared. I just shared this from a state perspective. So because I couldn't share sort of all these different individual states, I just picked the national picture. In states, the spending of hospital care and what percentage it is of the budget compared to prescription drug and physician services doesn't look very different from this national snapshot. One of the things that states are trying to figure out is, okay, we're spending a lot of money on healthcare within our state borders. On the commercial side, premiums continue to increase. On our public side, our budgets for state employee health plans and Medicaid also continue to increase. And we're going to have to figure out how to manage all of this for the consumers that are in our state as well as for our own state budgets. Because unlike the federal government, states have to actually balance their budgets every year or every 2 years, and they have to make really hard decisions when they have those questions in front of them. So one of the things that the questions they ask is, okay, what are the trends in the healthcare cost increases across the country? And you can see in 2023, hospital care spending grew by over 10%, and that is the largest swath of spend of our healthcare dollars. Physician services spend grew by over 7%, and prescription drugs, although it's a smaller piece of the puzzle overall in terms of what we spend, grew by 11%. So in some states, that is the highest growing piece of the healthcare spend that they see in their state, and so it's really worth analysis as to why and how the market conditions are really addressing that. Okay, next slide, please. Okay, so I've already talked a little bit about this. I talked about inflation and how that's a piece of the puzzle, but not all of it. I wanted to talk a little bit about high prices and utilization. Kathy talked about this as well. So one of the things when we work with our state leaders, they say, okay, what strategies do we have at the state level to try to address, curbing the increases in prices and increases in utilization? Because both of those pieces are actually contributing to the overall spend and increase in healthcare costs. So the US, unlike other countries, doesn't regulate prices. And so healthcare providers and drug manufacturers set the price for their services and goods. And as a result, we have, higher inpatient and outpatient hospital costs and prescription drug costs. The one thing that you have to think about is the prices work in tandem with utilization. And that is because the foundation of our healthcare payments, here in the US is based on fee-for-service system. So we pay for services that we incentivize. And we often incentivize more care. So we are using sometimes more services based on the payment methodologies that we've established here. One example, I just wanted to point out that, states who are looking into this and trying to figure out, where do we go next? One example of a price plus utilization that's driving costs is GLP-1 prescriptions. So state employee health plans and state Medicaid plans and also employers are noting that GLP-1s are driving up their overall spend on prescription drugs. The drugs themselves are approximately $1,000 a month before rebate. So they're not the highest cost drugs on the market, but they are really being, more frequently utilized for things like beyond obesity, for diabetes, cardiovascular, and the FDA is considering more approvals for conditions. So that's one example of, you're seeing a lot more utilization of a drug that's also then driving the spend. The other thing that I just wanted to note is our aging population. So we have a population that's rapidly aging and needing more medical care and innovation that has really resulted in more use of outpatient services that's really increasing the utilization and as a result, our overall healthcare spend. And the last thing I wanted to note is market consolidation. So over the past many years, our market has become more and more consolidated, and that's across national healthcare systems that own hospitals and different types of provider groups. That's with national carriers and health plans and pharmacy benefit managers that own pharmacies. So just as our system becomes more consolidated, there is just less competition and increased prices. And there's been a number of different research studies that are really digging into this if you're interested to see the impact of that consolidation on overall healthcare prices and spend. Okay, next slide, please. Okay, so what I wanted to just share here are states are thinking about how to address these really complex areas in different ways. And just these are just a couple of examples. There's more work going on than what's on this slide. But just for you all to get a taste of kind of what they're doing, there's this bucket of work that's really about how do we increase market competition to help, think about lowering healthcare prices. And there are states that are thinking about having more transparency, really understanding, provider ownership, thinking about oversight of transactions, exploring new contract procurement for third-party administrators and pharmacy benefit managers, and having state tax incentives for independent physicians so they can, not think about having to become, part of a bigger health system and have more consolidation. There is different types of work going on addressing prices directly. There is, I think, an interest in a number of states of thinking about leveraging Medicare rates as a reference price for other payers to at least have a benchmark of where, these prices can go. There is some interest in exploring adopting site-neutral payments for specific services. And there's also some interest in exploring, as Medicare negotiates rates for key prescription drugs, how can that be extended to commercial populations in states, and do states play a role in helping to advance that? And then there's a bucket about sustainability. So, and there's a lot more to talk about here about, workforce and how to ensure access and all of that. But just to focus in on two ideas. One is investing in primary care spend, really trying to understand when you invest in primary care and you have more prevention and you have sort of access to lower cost services earlier, you can impact the overall healthcare cost that comes later for individuals. And so, really focusing on that in an area that we have sort of under-resourced for a number of years is one strategy. And then there's states exploring, things like hospital global budget. So how do we move away from fee for service to think about, again, decreasing the incentive to have, higher utilization and thinking about having a budget overall for hospitals with more predictable payment and cost growth. And there's some states exploring that, including for rural hospitals who right now have some very specific challenges. Okay, next slide. So one thing I'll just mention, and we can get into more detail in the Q&A, is just the Rural Health Transformation Fund. There's $50 billion available, as you all know, from the OBBA. And we understand that states should soon, before the end of the year, hear if they're going to be awarded what they actually applied for. All 50 states applied for this Rural Health Transformation Funds. So we'll see how much each state will get. One of the things that will be interesting to see is with the money flowing in January 2026 and having 5 years to spend, there's a number of different really interesting and innovative ideas that states have set forth in their applications. And, for some states, it's going to be very impactful in thinking about investing in their rural health systems. And then last slide. I think, or almost the last slide, in Medicaid program. So I can't do this justice in 2 minutes, so I'll do my best. But I did just have to raise that states are really having to focus on their Medicaid programs. A number of states are going to have very tight state budgets this in 2026 and anticipating 27 and 28. And so thinking about how Medicaid, which is generally the largest spend of a healthcare budget or of a budget overall in states, how they're going to make decisions around what they're going to be able to continue, how they're going to be able to be more efficient, where they're going to be able to make investments, and what's going to make the most difference for the program. There will be a lot of discussion and work in that space, we anticipate, over the next many months. And they're also then, of course, having to focus on implementation of different provisions of OBBA, which is community engagement, the upcoming changes to provider taxes and state-directed payments, and the need to semi-annual redetermine individuals, which every 6 months instead of every year, which is what they had to do previously. So just a lot of focus and work going on in these areas that is going to have an impact on, people becoming eligible for Medicaid, staying eligible for Medicaid, and how providers will get paid as part of that process. Okay. And then last but not least, I think we have one more slide. Yeah. So just my overall takeaways for you all is I think it's if you haven't, spent time doing this, I really would encourage you to take a look at what states are doing in these various areas on access and affordability. Often there have been state ideas that have really been able to fuel national change at the healthcare level. I'll just give an example of the Surprise Billing Act, which actually was enacted after 15 states passed those laws within their state borders and tried to implement different things. And so it really can be, I think, an opportunity to understand how each state is somewhat different in their own financial and economic conditions for healthcare, but there is a common thread of the market, and the market extends beyond state borders. So I really would encourage you all to take a look at what your various states are doing and how that can inform what you're thinking about at the federal level. The second thing I would say is we have a lot of complexities in our healthcare system. And as you saw, sort of the challenges of affordability, are long-standing. So there's not going to be one solution that's going to be able to solve all of this. Really thinking about sort of multiple strategies across different types of ways to address healthcare costs and affordability will really be needed. And understanding the way that those solutions interact with one another will also be really important. And then the last thing I'll say is, we represent states, we work with states, but there's a lot of opportunity for federal and state partnerships as states think about and implement policies to address access and affordability. Drug pricing is just one example where I think the states are really interested in partnering with the federal government and understanding the changes that are happening at the federal level and how that can impact states. But there's many others, I think, to think about as we move forward in sort of trying to address this challenge. And with that, I will stop and turn it back to Alyson.
Thank you, Hemi. That was wonderful and a lot to cover. It's always so interesting to hear what's happening with health coverage in the states and how states are responding differently, and then how some of those lessons learned can be applied at the national level. So appreciate you bringing in that perspective and being open to hopefully outreach from some of the folks listening in about what's happening in their state in particular. All right, we're now going to turn to questions from the audience. We've already seen several questions come into the Q&A box. You can keep those coming. We're going to cover as many as we can. I'm going to actually turn back to something that came up, Hemi, in your presentation about the Rural Health Transformation Fund, and see if we can dive a bit more deeply into that topic. This is a question from an audience member, which is, how do you see, and I'll go to Hemi first, and then Kathy, if there's anything that you want to add on, please feel free to jump in. How do you see the Rural Health Transformation Fund affecting some of the issues you've talked about? And then more broadly, what are some of the challenges that rural communities face when it comes to accessing affordable health coverage and care?
Great question, and happy to sort of elaborate. So in terms of, maybe I'll just start with the challenges and then sort of talk about how states are proposing to address the funds and what impact it can have. So there's a number of different challenges in rural communities. One is certainly the availability of providers. There's just only so many providers that are in rural areas. Some are aging out, they're not going to be there. And with the population shrinkage that's happening in many rural areas, entities like hospitals are really having a hard time maintaining their budget because, as I talked about, we're on a fee-for-service system. So the fewer people you have, the harder it is to actually stay in business. So we have like two different things happening, or a number of different things happening at the same time. Like we have a provider challenge in and of itself, and then we have a sustainability challenge with the populations that are there. So I would say, in terms of the Rural Health Transformation Funds, every state, as we all know, are very different. There are states with sort of broad frontier rural areas. There are states with less of those types of rural areas. And there are states with like massive budgets, think California, and states with much smaller total budgets, like a state like Wyoming, just to name one. The $50 billion whatever portion that state will get is going to have a different impact given the economies of that state and the needs for that state. So in a smaller state that will have different, needs and really have been investing for a long time in rural health, this could be a very significant transformation with these types of funds in areas like, workforce. Thinking about EMS, one state told me like we only have a volunteer EMS, and if the one guy is not feeling well that day, we literally don't have anyone for certain parts of our state. So, really investing in those types of initiatives and thinking about how to sustain the rural providers that they have with different strategies is going to be really impactful and I think make a difference. There's some states that have been waiting to try to think about like new payment reforms for their different providers, particularly hospitals, but others as well. And they haven't been able to have like the capital infusion to help that system transform. And so they're seeing this as a real opportunity to think differently about how that hospital or broader health system can operate in a rural area. There's other areas where, people are thinking about like hub and spoke and really being able to enhance like telehealth capability and thinking about having specialty care that's outside those areas because the specialists are just not going to be in person in some areas of their state. And so having this type of funding to just be able to spend and make those investments, really the state feels like it could be very impactful. For other states, it's not going to make up the difference of, what they anticipate to be losses coming from people who are going to lose coverage, people who are going to, states that are going to have to make hard, decisions around provider payment levels. And so they have concern about, what we see is potentially difficult challenges for our community health centers, our rural hospitals, or other types of providers in those areas. This rural health money, while I think can be used in good ways, will not be able to fully overcome the challenges that they're going to be facing. So hopefully that gives you a sense of kind of what we're seeing.
Yeah. And I understand it's early days, right, with this fund, but it sounds like impacts will be highly variable state by state. Some states will have real opportunities for new kinds of investment, health system transformation, and in other states, it's going to be a real budget crunch that they're experiencing. Kathy, was there anything that you wanted to add in about access to coverage in care and rural communities broadly, or this new fund?
Well, yeah, I mean, just to add a little bit to what Hemi said, which I thought was right on. Rural communities have sort of demographic problems that make their health systems really financially fragile. The older, lower income, poorer health, as Hemi mentioned, declining populations in a lot of places, and huge distance issues in a lot of states that build onto costs and make things really difficult. I think the limitation of the fund is it's sort of a one-time shot, but the rural problems are not one time, they're sustained. But I think that it would be interesting to see if there were any innovations with different like delivery system modalities, like maybe more use of mobile care and, other things that might spread to other places and reduce costs. And so that would be, I think, kind of a win from this fund.
Great, thank you. I'm going to move on to another question from the audience, but just before I do that, I wanted to note that we have great questions coming in, several that are specific to pending legislation, and I'm just going to be straight with our audience. As a private foundation, RWJF isn't able to discuss pending legislation or things that are kind of the moment, which can be really frustrating, I know, as attendees, because you want to hear like, what do we think on this or that? We're going to do our best to really touch on the issues that are most relevant without us crossing into anything that could be perceived as lobbying. So just wanted to address that outright. So this question from an attendee is, has there been any discussion of how managed care organizations or value-based care, as opposed to solely fee-for-service, might help mitigate some of the rise in costs? Does this lead to healthcare access barriers as a trade-off? Whoever wants to jump in first. Maybe we can start with Kathy on this one if you've got a response in mind.
Sure. I mean, I think there's been a lot of experimentation with different kinds of value-based care. The Affordable Care Act for one of the things that I think it kickstarted was a lot of interest in, paying for value, not volume, and trying to transition providers and insurers into these risk-based contracts. I mean, I think on the downside, a lot of people feel like that fostered a lot of consolidation and a lot of hospital mergers, and people felt like they couldn't take risk if they weren't at scale. And so I think it did perhaps engender a lot of the sort of corporatization and consolidation of healthcare that in some ways people feel like has actually increased costs. The extent to which value-based care has reduced costs, I think it's still an open question, and really smart people disagree about it. I just watched a seminar at LDI a couple of weeks ago at University of Pennsylvania where there was a yes side and a no side, and both were were very, I think, well versed in the facts. So I think that means it's a hard question. There have been some experiments in Medicare that have been studied very carefully, and there are reasons to think that those are exceptions and not generalizable. There's other reasons to think that has spilled over to a lot of other care, so that it's actually not possible to measure the effect anymore. I think one thing is that Americans have resented certain kinds of utilization management, because when you do have value-based care or managed care, I think some of us are old enough to remember the HMO backlash. There has, it creates incentives to the opposite incentive of fee-for-service. It creates the incentive to sometimes limit care, or perceived as such by patients. So I think we've seen in our history episodes where there's been a very strong resentment against certain managed care practices. I think there's been a lot of foment about prior authorization lately. So I guess that's an answer that says it's complicated. It's not that it hasn't been tried, but I think it's not clear how much we have, been able to reduce cost growth with different kinds of payment reform methodologies. And while we 100% have to manage utilization, and if we didn't, healthcare costs would probably be 75% of GDP. We have to manage utilization, but it's not clear that we have a magic formula for, promoting value over volume that works for providers and works for patients.
Great. Hemi, was there anything you wanted to jump in on managed care?
Yeah, I agree with Kathy. I think the one thing I would add is just taking a snapshot of Medicaid, because, we work with state leaders on that. And, managed care has now become over 80% of how we manage our Medicaid populations across the country. So it is how we essentially deliver Medicaid services. It is also, with Medicare Advantage, a much larger footprint of how we're delivering Medicare services. So thinking about how to build value-based model within managed care, I think, is a really important piece of understanding where we go. I'll just say in the Medicaid space, been a lot of different value-based ideas. And to Kathy's point, I think it's been a mixed bag, honestly, in terms of impact. I will say we've worked with states that have really felt like they built, additional payments for, both providers and plans on certain metrics, and they saw an increase in quality when they really tried to attach value to those payments. But in terms of reducing the overall spend, I think we haven't seen, at least in sort of the Medicaid space, a true sort of decrease in those costs. So moving forward, states are thinking about, do we need more of a multi-payer solution? Do we need to think sort of more dramatically about more things like global budgets, which is essentially a value-based model? It's just one that you're really truly budgeting for an entire sort of set of services by the entire health system. So those are, I think, like a step further in the value-based model that we really haven't embraced across the country yet.
Got it. So pretty much like every healthcare story, it's complicated. But I'm going to move us, because we've had so many great questions come in. I want to move us to like a bit of a lightning round to get us through a nice trench of questions before we have to close. So the first question, I'm going to come back to you, Hemi. How does the current uncertainty around the ACA marketplace and other healthcare issues affect how states function?
Oh gosh.
I
That's a
know,
big
and I'm
question.
making you go quick on it too.
Okay. Um, I will say, with the healthcare marketplace specifically, we work with state-based marketplaces, so I really will only sort of speak for sort of that portion, not the FFM side. They are, heads down, how do we make this market work for consumers? So in terms of operations, their most important piece is, do consumers understand what their choices are and, what they need to do in the event that the EPC is not extended or there are other changes made. So I would say in terms of impacting operations, just to focus on a consumer and what do we do to make sure that they're informed. Sort of the broader, sort of state policy decisions, I really think encompasses not just Medicaid, but a lot of other changes that are happening that we didn't even talk about on this call. Changes to SNAP, changes to like overall like tax structure. I mean, when you think about a state budget, it's across everything, right? And they have to think about all these different pieces. So I guess I would just say like, not to overwhelm anyone on this call, but just understanding states, it's really helpful to understand the snapshot and where their legislature is going to focus on this year, because each state is going to pick where are we sort of on this continuum of like, is our budget better? Is our budget more challenging? And how then are they making healthcare decisions and on policy as a result? And where will the federal piece have an interplay?
Great. Kathy, I'm coming to you. What can we learn from the health insurance programs in other OECD countries in terms of addressing rising costs? For example, how would or could universal coverage affect health spending?
Well, that's a great question, and actually, a lot of people are talking about that lately. I mean, I think one thing about our system is there's a lot of complexity and there's a lot of administrative costs that a truly universal system wouldn't have, because we have, Medicare is obviously universal, but aside from that, there are a lot of different systems that people are churning between, and they change jobs, they need to re-enroll in coverage, so there's a lot of sort of dead weight loss that we spend just, kind of making people eligible for different kinds of systems. Your income goes up as $1. Now you have to go into a different program. So you could do a lot to save all that, and you could leverage a lot of buying power if you had, fewer buyers, and that's something I think we're exploring in different ways in this country already, but I think we could do more, but at the end of the day, you have to manage utilization. You could have, universal care, and if you didn't manage utilization, you wouldn't save any money. So I think there's some obvious wins with simplicity and leveraging buyer power, but you still have to find a way to manage utilization that seems fair and is accepted. And it's not always a garden party in the other countries because they're managing utilization there too, but in a way that's kind of the same for everybody.
I have a question about HSAs or health savings accounts. I'm wondering if either of you could take this one on. Would HSAs affect people from different income classes differently?
Go ahead, Kathy.
I was actually saying for you to go ahead. Well, yes. I mean, they give you a tax preference, so it allows you to let your money grow tax free, and you can pull it out and use it tax free. So the higher tax bracket you're in, the more beneficial that is for you. So some people look at HSAs as being a little bit regressive.
Okay. This is our final question. This hour has flown. From an attendee for Hemi. Among the 3 categories you showed for the newer state level approaches like consolidation, which do you think could work at a national level?
Oh, that's a really good question. I want to say all of them because I really do believe all of them, but I think probably if I could pick of the 3, I would pick the prices category. I really do think that's in terms of sort of national healthcare expenditures and where we would get the most bang for our buck. It's focusing in on the prices and how consolidation being a part of that, not the only piece of it. How do we have actual federal reforms that could actually address this in a more systemic way as opposed to a state by state way?
Thank you. So we are coming up on time. I want to extend a huge thank you to Kathy and Hemi for sharing their insight and expertise with us today. I want to thank all of you for participating in this discussion. We appreciate your time and interest and great questions. We've put a link in the chat for a brief anonymous survey. We appreciate you completing it to help us plan future events. We will be providing a recording of this webinar and the link to the survey as a follow-up. And that is it for today. Thank you and have a great rest of your day and a wonderful holiday season.